perioperative cardiac risk in non-cardiac surgeries. So it's the right time that we present our cases with respect to the same. So this patient, 63 years old male with hypertension and diabetes mellitus, presented to us with dyspnea on exertion grade 2 and angina on exertion grade 1. So we had a CTCA and the calcium score was 168 and it revealed TVD, triple vessel disease. So the other investigations were normal. ECG was in normal sinus rhythm and echo was normal. So we planned for a cath angio here. So I'll show you a short runs of the cath angio. So which showed a plaquing in LM, and then proximal LCX was 80%, OM was 80%, and LAD distal was a long segment 50%, and discrete distal was 90, and RCA mid was 90. So here our plan in this case was to stent proximal LCX, OM and RCA. So because into the case we found difficulty negotiating the OSTL LCX, so we ended up doing OSTL LCX stent and POBA to OM and stent to RCA. So this is the one. So where we put 2.5 to 21 sirolimus eluting stent in the RCA and just ballooning to the OM and stent of 3 into 18 sirolimus eluting stent into the OSTL LCX and proximal one. So this case, after 3 months, he was on this aspirin and ticagrelor. So he came to us with altered bowel habits, severe anemia, HB was around some 6-7, and severe generalized weakness. So we planned for the workup. So in the workup, we found that when we did colon after ruling out all the cardiac causes, so there was a sigmoid colon growth. In the PET, it showed primary sigmoid colon malignancy, and on biopsy, it was differentiated adenocarcinoma. So we discussed with our surgeon, oncologist, and we planned for a laparoscopic sigmoidectomy in this case. So my question, I'll stop my case here. So would like to have a discussion on what is the perioperative cardiac risk in this particular case of non-cardiac surgery, and how do you plan here? Yeah, the colon report showed a sigmoid colon growth, which is not bleeding, and this is the PET report, which showed a primary sigmoid colon malignancy and a differentiated adenocarcinoma on biopsy, and there are no mets there.
This
it's a local growth.
How many months after the angioplasty?
Sir, it's 3 months.
I think I'm a surgeon. In this particular patient, I definitely prefer going for surgery because you cannot stop it. So, going for a laparoscopic sigmoidectomy is the question.
Yeah, I'm able to hear.
So, laparoscopic sigmoidectomy, but I don't try to do an anastomosis because if at all patient is not faring well, probably this hypotension and everything, that anastomosis may not, will be not taken up very well. So I don't want to take the risk at that point. But because it is a sigmoid area, if it is a right colon, we need to, operate more extensively. For a sigmoid, I think it is a localized surgery. I prefer to do a laparoscopic sigmoidectomy and do a, colostomy and closing the distal, what we call it as a Hartmann's operation. And then naturally the anesthesiologists who are well prepared, they can take care during the surgery. And then if anything happens, so cardiologists are there to really tackle that.
So any cardiologists in the group?
Yeah. At this time of point, can we wait for 2 to 3 months?
No, we can't.
You can't wait. So in this scenario, like actually there are a few trials, TICO trial and all, that short depths also it's fine, like less than 3 months. We can cut down to single antiplatelet, then we can proceed for surgery.
But here actually it's defining the coronary substrate, coronary disease is really important. I don't think so that we just placed one single stent in a somewhere in the mid and distal location. we put a stent in ostial location of L6, which is near to LM. So this becomes a high coronary substrate. So how do you want to get into the surgery when there is a high coronary substrate? Like this is a high risk anatomy. So just by going, stopping one of the dual antiplatelets, going on a single antiplatelet, so is going to have a very, I think the traditional risk factors like RCRS may not capture the amount of perioperative cardiac risk in this case. Unless we plan properly, definitely there is going to be some event, major event into the case, maybe perioperatively or in the surgery.
If at all you stop the one anti-platelet,
yes, sir.
Yeah. By myself, underwent a stent actually. I was on dual platelet, and then within 1 month, I developed acute cholecystitis. They didn't stop anything, and then they operated. So in the same sense, nowadays I don't think with the available instrumentation, I think if we cannot stop the dual antiplatelet, we go forward with the situation like that without stopping it. We don't want to produce more risk on the cardiac side. So I think we can operate safely, probably with some extra care.
I will bring another discussion into this. Nice points added by Ravindra sir. And the way, and you evaluated this patient for anemia and he is losing blood, but your colonoscopy is not showing any active blood in the films. That means your dual antiplates are doing something here and that fellow is bleeding, right? And that is a chronic bleeding which was evaluated. So the different other perspective is the patient, that is not an obstructive growth. The scope has passed beyond. So there was no obstruction. That means it is non-obstructive growth, number one. And you evaluated him for the anemia. So the other aspect is, I will put it in the tumor board discussion. I will ask my medical oncologist, can we because you are saying it is so many red flag signs are there, I will not allow you to operate. So definitely, I will not completely withdraw. I will put it in tumor board and I'll ask my medical oncologist, can you give neoadjuvant chemotherapy in this case? Then my medical oncologist will switch into the literature and data. Operable colon cancer giving neoadjuvant therapy is an upcoming thing. There was no robust evidence. But still, have you ever tried? I tried. Because this is an outlier. Because he's bleeding and less than 3 months old PCA stenting. And there is an evidence to give neoadjuvant chemotherapy in operable colon cancer. The evidence is coming. And here, 2 things will happen. One, your heart will be taken care of once I'm not touching him and there won't be any stress. Second thing, if tumor starts responding, that losing blood will be stopped. The bleeding, what we are concerned, it's not an acute bleed, but there is a chronic bleed. He's losing slowly. That also will be taken care of. Yes, definitely this case will be discussed in the tumor board. Definitely. If you are resisting, I will ask my medical oncologist, give a neoadjuvant chemotherapy. By the time he finishes, he or she, it will be around 3 months. That means the post-PCA, you are almost crossing 6 months, right? Then I will be eligible to touch this patient.
Sir, if you have to touch this case in 3 months, so are you comfortable going on DAPT, dual antiplatelet therapy? Yeah, sir.
As an anesthesiologist, there are 2 things I would like to, answer. One is, what is the additional benefit that ticagrelor brings on ecosprin alone? That's one question. Because there's a recent study, very recent study that has been published, which compared the dual antiplatelet therapy versus single antiplatelet on long-term patients. And they found no difference in the outcome. That's one thing. Second thing is, there are new stents that has come into the market where the recommendation is that you can stop it as early as 3 months. I mean, cardiologists are there in the group, but you can stop it as early as 3 months before after the these new stents have been placed. So as an anesthesiologist, I would definitely like to take up this because squamous cell carcinoma, I think there is very good prognosis, am I right? Very good prognosis. So I would like to take him for surgery. Maybe 3 or 4 days you wait for the ticagrelor effect to be over and then take him up for surgery. I would like the audience also, the cardiologists in the group also to give their opinion.
Here the surgeon's main concern is bleeding. If I do anastomosis, post-operative anastomotic bleeding, that is the only bothersome complication I would anticipate in this case, because there is no obstruction. There is no proximal dilated bowel loop in this case. So the bowel edema will be less. But still my concern doing a covering stoma, as sir rightly mentioned about a covering stoma. But my only concern is bleeding.
Sir,
Post-operative anastomotic bleeding, because you cannot stop your dual antiplatelets as early as possible. I need to start because there is a high likelihood stunt thrombosis will be there. That is the only concern here, except that provided take that risk, go ahead.
Sir, as you asked one question about shorter duration of DAPT, yeah, that is there. So, but it depends upon the indication for which we started DAPT. One, for a stable case where we need to place like a single or dual stent somewhere in the mid and distal location of the coronaries, stopping DAPT within 3 months is completely valid, and that is there in guidelines. But when you go with an indication for a STEMI or NSTEMI, when there is an ACS, so the rule, the guideline says to continue DAPT for 6 months at least. But even only the cardiologist knows, it's not just placing the stents there. The length of the stent, the complexity of the case, the location of the stent. If the cardiologist thinks that anything is complex placing the stents, we would like to continue the DAPT irrespective of the whatever is said in the guidelines maybe. But even the guidelines say that you have to continue your DAPT if it is a complex case for 1 year. And we take this particular case as complex. Why? Because we placed a stent which is near to LM, and probably we don't want to stop DAPT anytime, like not less than 6 months, definitely.
Yeah, you can complete the case what you have done.
Yeah,
because
please go ahead with the
running
case.
out of time.
Yeah.
So, Anup, yeah.
Sir, so we got some bridging options. I would like to discuss the bridging options. So here it is like you continue aspirin, stop ticagrelor, you continue aspirin and continue ticagrelor going into the surgery, or you continue aspirin and bridge with a low molecular weight heparin, or continue aspirin and bridge with an unfractionated heparin, or continue aspirin and bridge with tirofiban infusion for 3 to 4 days prior to surgery. So if for cardiologist, he thinks about the amount of antiplatelet activity into the getting into the surgery to prevent any thrombotic complications. But if you see the antiplatelet activity, with aspirin and ticagrelor it is weak, with aspirin and ticagrelor it is strong, with aspirin and with low molecular weight heparin also it is weak antiplatelet activity. There is high thrombotic risk because heparin is not going to protect stents as much as an antiplatelet agent. Same with unfractionated heparin. But if you go with aspirin and with the tirofiban, the antiplatelet activity and the risk of thrombosis is going to be very, very low. So why is this important? You have this DAPT interruption in less than 3 months, and you're going for some major abdominal and that way cancer surgery, and you got a high risk coronary anatomy. So this is like a perfect substrate for having a major adverse cardiac event, which can go even up to 35 to 40%, means that every second or third patient on table, if you don't properly go for proper antiplatelet activity in the body, so definitely is going to develop an event. So how did we approach back? This was done 1 year back. We continued aspirin, we stopped ticagrelor 5 days back, and we went into the procedure giving low molecular weight heparin 2 times a day, 5 days before surgery. So in fact, we went into the surgery with like weakest antiplatelet activity, can I say. So on the day of surgery, a laparoscopic sigmoidectomy was done. It was nearly obstructing tumor. Anastomosis was completely successful. No immediate surgical complications were there. So while surgeon was doing the skin sutures, there was a call from OT that it's BT, and our anesthetist delivers the shock immediately. So after the delivering of the shock, we did ECG. This was the ECG. On surgical table, so this is the ECG of the patient. And the echo done was fairly normal. Patient had VT, 1 episode of unstable VT, shocked. Sir, as a surgeon or anesthetist, how would you proceed? Looking at the ECG, you see in this ECG there are no ST elevations, and echo is also fairly normal. So, do you want to proceed further? You want to take take the patient to ICU, or you would like to have a angiogram or cardiologist's opinion? If the cardiologist says that he wants to do angiogram, how comfortable are you in this case to get an angiogram done?
As an anesthesiologist, I would be very uncomfortable taking, because once you go to the cath lab, the cardiologist is going to start some more antiplatelet therapy. They've just undergone a surgery. He's going to bleed like hell after that, especially if there's an anastomosis. Everything is going to bleed a lot. So I would prefer to take him to the OT.
My job is already done. Skin staples already, no? So,
Sir, but you have to take call with respect to the bleeding. So how comfortable you'll be? Okay, fine. I'll go with the case.
no, we have to save him. The bleeding is the secondary thing, and it will be consequential.
They have anastomosis.
Yeah, done, sir.
I feel if I am in that situation, I don't anastomose, because anything odd happen to the cardiac side or a bleeding side, the anastomosis may really give way. So I want to be safe at that point.
Sir, actually, the VT appeared when the final skin sutures were being done. In fact, almost the procedure was over. The final skin sutures were being done.
What is the recovery process and then healing process? So we have to definitely consider that. It may weak actually. There is a quite a big possibility. Suppose he has not done some colostomy or a ileostomy, covering ileostomy, then it is a really big issue actually.
Okay.
No, sir, any surgery, there will be raw areas, and that is going to bleed.
Anup, can you complete the case and then leave
sir.
the discussion open?
Yeah, sir.
Please. Yeah.
So the cath lab, we came there and we saw the ECG was fairly normal, but the echo was fairly normal, but we know the coronary, it was a high risk coronary anatomy. So we thought that this VT would be definitely due to some thrombosis would have happened to the stent. So we asked our surgeon, and our surgeon told that okay fine, we spoke with our anesthetist. So they told that okay fine, if you want to go ahead you can go. So we did this angiogram. So that's the angiogram. We can see a huge chunk of thrombus sitting between the LM, LAD and LCX. So it's in that important junction. So it's there. So these are the other angiogram things where there is a thrombus, and in fact the RCA stent was patent. So so you can have multiple decisions. You got thrombus, you can remove the thrombus, do thrombosuction, but we planned for a tirofiban infusion. Just we wanted to check because this is the antiplatelet agent. So we want to check with this antiplatelet whether the thrombus gets resolved. But for us the thrombus resolved partially, at least 60 to 70% thrombus was cleared on tirofiban infusion. This was the check shot. We can see much of the thrombus being cleared there. So we were happy. We don't want to take wire and then spread the thrombus. So we shifted the patient to ICU. We had this IV tirofiban infusion for 24 hours. We continued aspirin. We loaded patient with ticagrelor within 24 hours. And we put the patient on heparin infusion after tirofiban infusion after day 1 for 2 to 3 days. We monitored drain and hemoglobin. So in post-op first 2 to 3 days, the EF dropped to 40% LAD territory. And in the first initial 2 to 3 days, we had drain output of 200 to 300 ml. So HB also dropped. We transfused with PRBCs. And then slowly the patient recovered. The EF improved to 50%, and there was small rectal hematoma which was squeezed out. So this is the important thing, like 3 hits model in the oncology cardiology circles, not like in the guidelines. Whenever you withdraw the platelets, that's the first hit, and the second hit is when you're going into a proper surgical cancer surgery. And the third and the biggest hit is like you have a high risk coronary anatomy. So if you have all these 3, definitely are going to have that perioperative cardiac risk unless you don't plan into the surgery properly. So what could have been done differently in this case? If given the case today, probably instead of going with a low molecular weight heparin bridging, I would definitely go with a cangrelor bridging. So probably I would stop P2Y2, and then I would start after 1 day of stopping ticagrelor, I would have started IV cangrelor, and then cangrelor would have been continued till 2 hours before the skin incision of surgery. And then after the surgery, within 6 hours, I would like to start aspirin, and 24 hours ticagrelor or clopidogrel, and then it's not necessary to the bridge in post-procedure cangrelor. So these are the guidelines which say bridging with so what we did right in this case. So the first and most important thing we did right, despite going into the case with a weak antiplatelet activity, what we did right in this case was the rapid recognition of ischemic VT by our anesthetist. So she gave the shock initially looking into this. She was able to recognize it. So or else the patient, it would have been difficult. So the next was our team effort with immediate cath lab activation, and we were not hesitant in starting the antiplatelets within 24 hours. And ultimately the final thing was the entire team which coordinated well to discharge this patient safely. Yeah, thank you.